Hi everybody, welcome to our Facebook Live. This is going to be the last Facebook Live of 2020. I'm Kim Fogarty. I'm one of the physician assistants here at Jemsek Specialty Clinic. I'm here with Dr. Jemsek, and we're looking forward to answering your questions and giving you some hopefully beneficial information regarding Lyme borreliosis complex and how to further your health. Please know that we are only able to discuss general aspects regarding health and Lyme borreliosis complex. We will not be able to discuss specific treatment strategies or specific entities regarding your own health. And also, please note that this live stream is supposed to be educational. It does not replace a medical consultation with your provider. First of all, starting today, Dr. Jemsek would like to continue his discussions regarding roadblocks to treatment and therapy for Lyme borreliosis complex. Two roadblocks that he wants to discuss today are periodontal disease as well as IRA syndrome. Dr. Jemsek?
Thank you, and good afternoon, everyone. Thank you, Kim. Those were great disclaimers. So yeah, we're working on the roadblocks. We have about 24 or more, and they grow slowly, but there's a lot of things that either preempt or should preempt giving care or complicate care so that you can't have a successful conclusion. And the two I want to talk about today, if you remember, when I first brought this up, I think 3 or 4 sessions ago, we talked about babesiosis, that's number one. And I wanted to talk about toxic relationships and some other thing when Jules Capon was here co-hosting. Today I'm going to talk about periodontal disease, which is not very exciting, but it's something you need to list. Severe periodontal disease can range from infected tissue to gross cavitation and root canal infections through tubules in the teeth that the spirochete actually invades, to osteonecrosis. So the bones in the jaw are actually infected. So we've seen that a number of times. If you think of someone that has very poor dental hygiene or it's been severely affected by these infections, and you understand also that we have normal flora in the mouth. In fact, the mouth is a very dirty place, figuratively and literally. Lots of bacteria, including non-pathogenic spirochetes. But once the tissues are damaged, there can be opportunistic infections there, and if the spirochete's there, which it is, and some of the other co-pathogens there, cause a great deal of inflammation and damage. Now, we've had a couple people who the last step to getting better was, and this was extreme, is total dental extraction, and that made the difference for them. Now, I'm not advocating that, but we just had a handful of people that was necessary. So you need to be careful and make sure that everything is in pristine shape. If, for example, you're going to do dental implants especially, you may want to bridge to that, and there are all sorts of other considerations in that regard. So this is one of the 25 or so roadblocks that I want to discuss with you, and it is important. And another thing, when you're doing mouthwashes, don't use an alcohol-based mouthwash. In fact, I think Crest and some of the other big boys have gotten away from alcohol because it really excoriates the tissues. Doesn't do much to kill the bacteria. So the best mouthwash is a hydrogen peroxide-based mouthwash. And by the way, many of them have xylitol in them because, as an aside, a note of interest, historical note of interest, Procter & Gamble discovered xylitol as a biofilm buster decades ago. So they were including xylitol and sometimes lactoferrin, which is as most people know, is our go-to biofilm disbursement program. It was already in the mouthwash. Now, when people rinse, and I don't think it really raises the level of xylitol appreciably. Okay, that's periodontal. Next is immune reconstitution syndrome or arthralgia, so IRA, IRS. As a HIV/AIDS physician for a very long time, I remember distinctly that once our patients were getting better in the 90s after finally getting a combination triple therapy with protease and agents being on board, people started to survive. Immune system started to recover, And there was a reconstitution phenomenon such that dormant infections would be reactivated once the immune system was able to see them, because prior to that they were tolerated. So the same things happen in Lyme borreliosis complex, which is our discovery, by the way. And because of the way we treat with sequential therapies and pulsing and following patients carefully and looking at healing and on the physical examination, healing and the quality of life, there are three areas that tend to recur or intensify or begin anew. And this is after all the neurocognitive and energy level issues are restored. Hence I call it immune reconstitution. I guess we recognized it maybe, 4, 5, 6 years ago? It's been a while. Mm-hmm. And no one else really talks about it, but it's so real. It's like 30% of our patients. It's incredible. We don't tell our patients this may happen. And it doesn't mean the end of the world. It just means that we need to redouble our efforts. So what's happening, in my view, is that organisms, secondary organisms, not so secondary really sometimes, Mycoplasma pneumoniae, Chlamydia pneumoniae, are part of the Lyme cabal, if you will. Well, actually there were doctors I had in the Lyme cabal before, but in terms of organisms, pathogens, sort of the same, isn't it? The immune system, of course, is immunocompromised, but it's angry and making noise, but not controlling anything, which happens with COVID, too, in the severe cases, by the way. So it's playing catch-up, making lots of noise, making you miserable, attacking sensitized tissues where you're more vulnerable and your threshold for pain and all kinds of abnormal, undesirable activity is reduced and triggered at a lower level. As you get better, as your immune system first strengthens and then focuses, now we've got an immune system that's rebuilding, it's ahead of the curve, and we want to extend that difference as much as possible. As we do that and have strengthened the immune system just through feeding it for months of therapy, and on the preface of people restoring to a very low inflammatory lifestyle, being very good about detox and living a clean life to the extent possible. I mean, life happens. You can't control everything, and you have to live your life, but you have to take it in steps when you've been really sick. So what happens, in our view, with about 30% of our patients is that the immune system is now recognizing species that it tolerated or ignored before. And I think those species are chlamydia and mycoplasma, both single-cell, cell wall-free organisms. And so all of a sudden you have a patient much, much better on maintenance with us, 3 days a month. And all of a sudden now they got migratory joint pain, pain that goes from one joint to another. Sometimes it's swelling, usually not. Or they may have funky rashes that they didn't have before, they're worse than ever, and occasionally some neurologic symptoms. So we've identified this as immune reconstitution syndrome, IRS, or we started calling it immune reconstitution arthralgia because there was so much joint involvement. And in fact, the last patient I saw this morning had that to some extent. So we target the mycoplasma and chlamydia with the best drugs that we have available, including minocycline, rifabutin, azithromycin, or clindamycin. And we do combinations, and we'll treat 1 to 3 times a week on the off weeks, weeks 2, 3, and 4. And our experience, and this is really pretty cool, it plays out that 6 to 8 months and everything's gone. I would say 85% of the cases. Now, you can't have any consternating factors. To complicate this, you got to be sure there's nothing else going on and that people aren't reactivating for other reasons, like one of the roadblocks, for example. But immune reconstitution syndrome. So our patients don't get discouraged. I explain it to them. I say, you're going to be fine. It's just kind of a pain that you have to take a little extra therapy for a few more months, but guess what? It's going to go away. So immune reconstitution syndrome. We'll have more roadblocks next year.
Okay, so now we're going to get into our question and answer. We're taking questions from our Instagram page that you guys submitted earlier, and also our Facebook page that you submitted earlier, as well as our running feed currently. First off, the topic of COVID. Understandably, we've been getting a lot of questions and inquiries regarding the ongoing COVID-19 pandemic, and we would like to address those first. To start off with, Dr. Jemsek, do you have thoughts regarding the newly released COVID-19 vaccine?
Well, it's unprecedented to come out this soon, and obviously hand in hand with that goes the fact that we don't have data immunologic data on the effect, not enough data anyway. I mean, obviously there's data got approved, at least one is approved. So from the very beginning of the pandemic, we have advocated for the protection of the high-risk folks and those on the front line. And we've said, target those people primarily because that's where your index of mortality and morbidity occurs. There are also a few low-risk people who have unrecognized immune defects that predispose them to illness. It'd be nice if we had a screening test. There's some studies out there. It'd been really nice if we had this some time ago. We feel we recognize the tragic loss of some of our frontline healthcare providers and consider them heroes. And we want them to partake of the vaccine, and we're in sync with the recommendations. But we feel like we need to learn a little bit more as time goes on, and we will. And we follow the immunologic and clinical outcomes of thousands and thousands of people getting vaccinated. So we have a lot to learn, and it's a moving target. But we're in full accord with targeting the susceptible and the frontline healthcare workers. Thank you.
As we're learning more and more about the COVID-19 virus, we're understanding the severity of the inflammatory response and the impact the virus has on the immune system. Dr. Jemsek, could you discuss a little bit about that?
So everyone knows or should understand that we are 100% Lyme borreliosis or tick-borne illness clinic. Doesn't mean we treat every single patient that comes in the door. Not every single patient needs therapy, much less aggressive therapy. We try to be very discerning. And most of you know that I consider Lyme borreliosis complex to be a opportunistic infection, and that our patients who evolve into this illness are colonized, if you will, by a group of pathogens that become opportunistic, just like HIV/AIDS. So people with HIV/AIDS, when their T counts drop low enough, they begin to die from pneumocystis pneumoniae, CMV retinitis, disseminated Mycobacterium avium, and things of that nature. Those are things that are in our body right now that our immune system controls. Hence the importance of the immunologic control. It's all about immune control and focused immune control. So what we've seen in our population is I have treated our own patients who have had early COVID infection. I've given lectures on how to protect yourself with a set of supplements, which are on my website under my lecture series, and a lecture I gave to a London group. And I've told everybody individually about what I'd like them to do, and with great acceptance. And I feel very confident in that. There's very good academic support for what we're recommending. But we did discover the key element and integrated it. And we'll see if it becomes nationally accepted eventually. Here's what's happened to a few of our patients. Patients that were stable have developed rather severe manifestations of COVID before we could intervene with them or protect them. And we've seen a handful of folks who have become morbidly ill. I mean, it's really quite alarming. And so the question is, did COVID do this all by itself, or are we reactivating Lyme borreliosis complex or some other illness that we don't know about? The fact is, if you go back to our basic precepts, we feel like there are a set of triggers that are stressors that continue to destabilize and thin the protective immunologic barriers over time. And that can be physical, emotional, infectious, and so forth. And I think most of our patients understand that. Many of them had, oh yeah, that's when I got sick, this happened to me. But if you look back, there may have been some smoldering symptoms earlier. So what is COVID other than a major inflammatory storm? So if we have millions of susceptible folks carrying Lyme borreliosis and Babesia out there that are unrecognized and compensated because they don't eat gluten, they exercise, they take vitamin E, they follow the infomercials and take the supplements, they get a bed that reclines or doesn't recline, whatever. They do all these compensatory things that work for them until they don't work, at which time the disease just runs along its merry way. So what is COVID? Why is COVID not another major stressor, for goodness sake? Why is it I mean, it's probably the biggest stressor that I've seen in my lifetime. And so that begs the issue, and we have a conundrum here, because there is a study out by Pieri in April from the NIH, and there was which says that we're seeing too much neurocognitive stuff in people out 3 to 6 months from this illness. And there was a more recent study saying that 20% of patients with COVID have neurocognitive issues at 3 months. And so we're going to, follow those. Is that going to go on to 6 months, 9 months, a year? Question, it begs the issue, is this COVID? Because we know COVID attacks the brain. So you're going to see a lot written about COVID. Is it COVID primarily? Does that mean COVID's chronic or relapsing or recurrent? What does that mean? Or does it mean that COVID triggered reactivation of Lyme borreliosis in susceptibles or newly diagnosed individuals or some other illness? So I think that I'm putting a different spin on it for everyone, which we're going to lose that discussion, unfortunately, because most of the world doesn't recognize Lyme borreliosis complex as a chronic illness. And so we'll just wait and see. Maybe COVID will be a segue to looking at Lyme borreliosis in some way or form.
Thanks, Dr. J. Now we're going to start answering some additional questions that have been coming in, and thank you guys for your participation and your comments. We've gotten some questions about appointments, and our DC office continues to be open, and we are taking new patients. Please contact our scheduling department at 202-955-0003, and they can walk you through our patient intake process and how to prepare for our appointments and get ready for our appointments, and how our scheduling procedures are performed. We do use virtual appointments for some patients if it's available and if it's pertinent to their health care. Dr. J, could you? We got a question about and mold. Could you please discuss how that can impact patients with LBC?
Well, I'm not the expert, but I know enough to be dangerous, I think. And looking at the issue about the various resins and binders and treatments and so forth, and the various mycotoxins involved for the various fungi, whether it be aspergillus or penicillium or stachybotrys, I don't think anybody really knows for sure what works the best. And here's what I do know. If someone's, and we're learning more about this, if someone has been exposed to mold and currently exposed, and it's an intense situation, we can't get them better. So it's an accelerant in that regard, or a deterrent, whichever way you want the arrow to point. And it's a real issue. So it's one of our roadblocks, actually, that we'll discuss later. And we've uncovered this, quite a number of times. And we're getting better at screening and understanding. The other thing that I know is that if we do treat, let's go low and slow. Let's not do ETTA. Let's not do, heavy, resins and that sort of thing. Because you destabilize the body to such extent that you get excitation and oxidative stress, and the patient just, takes a nosedive. So we'll do things, at the moment, we're doing things like citrus pectin, starting out slowly, building up. We'll do things like activated charcoal slowly, maybe once a week, twice a week, carefully, apart from medicines. And we'll do chlorella. And then we do gut health in general. We try to flood with probiotics. And if our patient can tolerate fermented foods, that really favors the colonization of our native bacterial flora. So we really push on fermented foods if they're able to tolerate them. If they can't tolerate them, it's usually a histamine issue, and we may try to nullify that by diamine oxidase DAO, which is a natural enzyme, breaks down histamine in the gut, where 80% is formed, and nourish the gut with butyric acid, propionic acid, coconut oil with lauric acid, and so forth. Knowing about mold, so mold is not the driver. Mold doesn't do this disease, but mold certainly can complicate this disease once you're in an inflammatory storm, you have a dysregulated immune system. Thank you, Kim.
And just some additional comments regarding environmental toxins, whether it be mold or secondhand smoke or allergens. One thing that we find to be helpful, if possible, is to actually remove the source of the irritation, whether that be have somebody smoke outside or remediate mold in the home. Also, air purifiers of small space heaters can be put in main living areas or bedrooms that can also be helpful to reduce contaminants. We get questions about how JSC goes about treatment in general, and we view this illness as being a complex entity of a group of infections that work together to destabilize and override one's natural immune functioning. So it's what we do is we use combinations of antimicrobials to systematically decrease the infection load within the body while offering support and encouraging one's own immune system to get back in charge. It's really important to stabilize sources of stress, and Dr. Jemsek has mentioned his poems, and also, again, the Roadblock to Recovery series are things that can inevitably help to promote the immune recovery. Oftentimes, we find that if someone plateaus in their treatment, it's usually related to an ongoing co-infection or a defense mechanism such as biofilm, or an unrequited stressor that is impacting their body and keeping them from reaching a full remission state. Dr. Jemsek, could you please talk about how JSC targets biofilm?
So for years and years ago, I knew about biofilm always, and a number of years ago, well, I was afraid to break down biofilm too aggressively because I knew it was going to implode our patients, and when I didn't have a decent plan or experience, I used nattokinase, and you know, nattokinase is, as some of you know, is part of our COVID protection package, supplement package, a very key part of it. I like it because it's gentle, it's soy-based, but there are soy alternatives. It's safer than aspirin, probably wouldn't take it with anticoagulants, however. At any rate, I used it, and the rare individual had a big herx, but mostly not much happened. And a few years ago, as I looked around for what was available, I discovered Montana Surgical Research Group and called the people out there. And their biochemists had discovered that in their patient population, where they're dealing with amputees, diabetics, you know, gangrenous limbs, you know, horrible infections, they thought, well, maybe biofilm's playing a role. Duh. Biofilm's everywhere. Biofilm is a polysaccharide with multiple pores, with multiple organisms living within it, and it's a dynamic phenomenon, and it will shrink and evolve, and organisms will come and go from that space, and when they're in this space, they're in a dormant state, very hard to be killed, very hard to penetrate. As I mentioned earlier briefly, xylitol is a sugar alcohol, like stevia. They're really identical. Xylitol's from white pine bark or corn cobs, and stevia is from the stevia plant. So I chose xylitol because it was easy to work with. And I talked to the surgeons out there, and they said, don't take too much because you get diarrhea and you make the patient very sick. So I said, fine, and then we used lactoferrin as a resin to bind iron, which is the main heavy metal in the biofilm. So biofilm is polysaccharide, and so xylitol acts like a detergent. And so we give it in measured days, and we tell the patient, under no circumstances can you take another sweetener, even though they're not all sugar alcohols. So certainly erythritol and stevia are definitely off the list. Sucralose is trouble. You know, monk's fruit and some of those other things I can't really say. I think they're maybe okay, but I tell people if they want something sweet, use honey, because it has the least fructose of anything out there. And we learned that the other concept that you have to understand is that if you're going to use biofilm, you can't use it willy-nilly. You have to kill what comes out of the biofilm. Otherwise, the organisms will go back to a planktonic form or live type form, invade other cells, neurons or epithelial cells, whatever, kill them and make more biofilm. So you can develop a microbial chaos, I call it, microbial chaos. So it has to be measured in time. So it's like a battle strategy. And we found that xylitol is terrifically reliable in doses of 8 grams or 2 teaspoons of powder, taken usually the first 5 to 8 days of our program, depending on what we're doing. And we feel it's absolutely essential. Otherwise, quite honestly, if you're really sick, how can you get better if you don't attack the reservoir, which keeps being formed and reformed, of all these pathogens? You can't. And so that's a key difference in our program from many, many other programs.
Dr. J, there's been a lot of discussions regarding disulfiram and its use in treatment in Lyme borreliosis complex. Could you please touch on your thoughts?
My thoughts are that we're not going to use that here, and because we pretty much feel like we have a sophisticated program that continues to evolve and doesn't require disulfiram to get better. Having said that, I am very sympathetic to the millions of people who can't access decent care, who want a simple solution and answer. It's not going to exist, folks. I'm sorry. Now, that's not to say that disulfiram at some level may be an adjunct to therapy some way, but that's going to need pretty good research, and we're dealing in a framework where we don't really know our hypotheses or know how to prove them. So we don't have plausible hypotheses because so much is unknown. That's a huge issue with any kind of research. So if somebody comes out, I'm not critical. I just say, no, we're not going to do that. We don't need to do that. And if they insist on taking us, that's fine. But we don't feel comfortable doing that. And good luck.
We've gotten a lot of questions about Herxheimer reactions or herxing due to a inflammatory response that occurs when the tick-borne illnesses are exposed to antibiotics or are killed. Potentially any issue or factor that's being caused by or contributed by these infections has a potential to flare, and this could be issues regarding the nervous system, issues regarding the gut, issues regarding the musculoskeletal system, the skin, and so forth. It's, as we've said before, it's really important to help moderate and mitigate any source of stress on the human body and try to maintain balance as much as possible, and that includes the intensity of herxing. What we do is we have different strategies that are tailored to the individual that help to support these tissues and help to address the inflammatory response that occurs with treatment in an effort not to overwhelm the system. You don't want to run in and bomb one's body because it can actually send the immune system railing and create a lot of confusion. So we do see Herxheimer activity in our patients, but it's really important to do everything in our power to make it as less intense and as balanced as possible. To use Dr. Jemsek's analogy, it's like dealing with a burning house. We probably will get hot, we may get a little bit sweaty, but by no means do we want to get burned or catch on fire. Dr. Jemsek, in that regard, how would you give some advice to family members and support people who are helping patients who have a significant amount of Lyme rage or depersonalization as a part of their illness?
Yeah, tough situation for family members. The optimal situation is to have some counseling with a professional or someone in our group or a similar group, I suppose, so that the unregulated activity of the limbic system and is understood by the caregivers, because it can get ugly. And patients who are depersonalized, I think, are the most frantic of all. I mean, I'd much rather have patients that have hallucinations because most of them think they're funny. And if they don't think they're funny, then I'll medicate if they're frightened. But when you're depersonalized, that's a horrible feeling. And with the rage that happens because the amygdala is on fire and the prefrontal cortex can't counteract it, so you're getting these, so remember, the lower brain doesn't think, right? The limbic system don't think. It don't think at all. It's the reptilian brain. And it fires off, and it can just lead to all kinds of chaos in the family. So I've actually talked to Jules this week, and I asked her about this, and she's more expert than I. Where there's a family member involved or a child even, and they're raging and they're threatening and they're irrational and they're saying, ugly things, the response should be to, I'll talk to you when you calm down a little bit. I'm going in the next room. And if you can leave that person alone, that is. If you can't leave that person alone, then say, I'm going over here and I'm going to do something until you calm down. You don't criticize the patient. You don't ridicule the patient, and you don't argue with the patient. And when they calm down, you try to reassure them. So it's really, really hard. I mean, it's easy for me to say that, but if you're in a situation you're being screamed at and called various ugly things, it's hard. It's very hard. But in the long run, you have to understand it's an uncontrolled emotion that doesn't totally forgive the emoter. It doesn't. It really. They need to have, if they can grasp some superintentorial concept of that they're being very bad, they need to tone it down too. So in time, I think that would happen. But it's very tough. One of the reasons that this disease is so hard to treat and so difficult, and our patients are so frantic from time to time, and their caregivers as well. So the best situation is to get in here and, okay, here's how the brain works. It's really hard. We're going to try to medicate without drugging the patient to calm the brain down and get them in a better place. We're going to restore sleep in a healthy way. And then we get on with our treatment, and hopefully in a few weeks or months we'll see a much better situation.
Dr. Jemsek, we have questions regarding if age can predict how you will respond to treatment and if you will be able to actually achieve a remission. Could you comment on that?
Thank you, Kim. So it's good to be young, just put it like that. Unless you've gone through, you missed your whole childhood because of this illness, which we see a lot. It's very sad. With age, we get a natural deterioration of our innate and adaptive immune systems, which work together. Innate's on the front, adaptive's on the back. It's the one that makes the T lymphocytes or generates clonal expression of T lymphocytes and B cells and makes specific antibodies and cell antigens reactions. And that's why the elderly are at risk for COVID, quite honestly, because COVID gets past the front door and the front gate and the front door, and then we get that inflammatory storm I referred to before, and then we're off, and then people die because they start clotting and, have widespread infection and so forth. So we have the same kind of process with Lyme borreliosis, and in the elderly, they don't have the their baseline immune status is already damaged, but the baseline as it was is already diminished. So it is a bit tougher to get better, but it is tougher, but we can get people better. You clearly can get better. Now, sometimes in the very elderly, octogenarians and even older, the idea is not to be aggressive and get into a program with Jemsek. The idea is to take a little bit of suppressive antimicrobial that you can tolerate, that's safe, that doesn't interact with any other medicine, not too much, and more often than not, things will calm down, and that's a win.
We frequently get questions regarding how to determine whether or not somebody has reached a remission state versus an ongoing infection. And one of the ways that we organize our antibiotic protocols is in a pulsed fashion, which allows us to tease out patterns and windows. We look at patterns of reactivity on the antibiotics with the Herxheimer reactions that we were discussing earlier, and also how patients are doing off the antibiotics, because that oftentimes demonstrates how well their body is able to handle the inflammation and how stable the natural immune functioning is. And it's very interesting because even though every patient is very different and every case is different, every treatment is different, we'll see similar patterns as we go through. So the ultimate goal is to get it to where there really isn't any difference between being on or being off the antibiotics. And generally, That also is accompanied with significant improvements in symptomology, significant improvements in physical exam findings. Now, when patients reach a remission state, keep in mind there's tissue that is still fragile. Neurologic tissue heals the slowest in the human body. And so oftentimes, even in a remission state, people will gradually continue to get stronger and improve as this healing process occurs. Now, as with any type of injury to the human body, whether it be a sprained ankle or a paper cut, there's a potential for scarring. And so certainly we take into account that there can be potential scarring within the brain, within the peripheral nervous system, within the gut, within the musculoskeletal system. And so understandably, as much as we would like to get our patients back to 100%, that would be an incorrect thing to say and an overzealous thought. But we usually will tell patients that, again, keeping the body supported, keeping the inflammation down can also promote that further healing and recovery. Dr. Jemsek, could you please discuss your thoughts and information regarding allicin and how it can be used in LBC?
So allicin is a immune modulator that some patients find very helpful. It's not our front line. It's not on our front line, but if people come in and say, "I want to take allicin," and you can smell the garlic across the room. That's fine. We're not against it. We're not against a lot of the supplements. We just have what we consider a front tier. That is front tier, top tier, I should say, and of supplements which focusing on being neuroprotective. And I think the best of those are in the curcumin family, and certainly the most articles written about curcumin, resveratrol. Careful with resveratrol in women that have estrogen-sensitive history of malignancy, because it's a mild phytoestrogen. I think quercetin is very good. A good omega-3 is very, very good, or krill, which I think are pretty much equivalent. Debate's still out. Vitamin C. But, I mean, there are so many supplements out there. Anybody else notice that the industry is booming, just like gluten-free products are booming? What's going on out there? So if people bring their supplement list in and it's, there's on 25 things. What I don't like is a supplement product that has 60 things in it. I just don't like that. And so that makes me nervous. But things like allium as second-tier products, if we can keep our supplements under 10, let's say, it helps the pocketbook, it helps the gut, I think, to some extent. And I hope I answered that satisfactorily.
Dr. Jemsek, could you please discuss your experience in terms of how Lyme borreliosis complex can affect the lungs? But the specific questions are regarding coughing and how it can cause some burning in the lungs.
So the pulmonary, the lungs are a big place, and I think, and I don't know what Kim thinks, but I think maybe 5 or 10% of our folks that are non-smokers, non-asthmatics, that's their first complaint. 5%, 10%, starting coughing, and not productive, and not necessarily short of breath, not necessarily wheezing, but we think that sometimes we see the first sign of activation in the lungs because we know the spirochete lives there, we know mycoplasma lives there, we know Bartonella lives there, chlamydia. And so that is not at all unusual. Or as time goes on, people develop a cough or start to have respiratory symptoms. And some of this is brainstem, as most of you know, air hunger. That's a medullary lower brainstem issue. This is not what we're talking about. There are all kinds of nasopharyngeal issues. You have glottis issues with the cords, and you have dysphonia with palsy to the cords, so that people can't speak correctly, they get hoarse. There are all kinds of things going on, but we don't discount it at all. Even, as I said, if somebody's a heavy smoker, that's one thing, but we generally see it in those people that have no risk factors, never had this before. As far as burning, on exam, we'll check and see if you have pleuritic component, which is uncommon, but it happens. So in other words, is where the pain fibers are in the lungs. There's no pain fibers in the lung tissue itself, but on the outside the pleura, that's why pleurisy hurts. It's very tender. But much more common would be interstitial, either myofascial pain or radicular pain coming from the thoracic root, for the thoracic cord, for example, innervating the rib cage. That would probably be more likely. So we do firm palpation all around the ribs. And one of the things we found a lot lately is, in the last year or two, is the lower floating ribs in the axilla on the side, like all the way at the bottom. Those guys can get really touchy and tender. And it hurts to move them, so it hurts to breathe that way. So, we talk about hot packs and stretching and topical CBD or topical Voltaren, diflucanac. So that's another way, but also carefully listen to the chest to make sure there isn't anything there. It's not usually there. It's usually in the muscle groups or it's a neuropathic thing.
Dr. Jemsek, we frequently see tinnitus, which is buzzing or ringing in the ears, and sometimes I've had patients describe it to me as like crickets chirping or even somewhat of a low hum. This can be associated with hearing loss and sometimes with normal hearing. Could you talk about how and why that occurs in patients with Lyme?
So I think there were several etiologies. There was an interesting study done a decade ago at Georgetown, which imaged people who had chronic tinnitus. And they found that when they looked at the entire brain, an area called the nucleus accumbens, which is actually a reward center, it's dopamine rich, was the one that lit up, suggesting that there were neural pathways that reflected this tinnitus, not just the eighth nerve or the vestibular nerve, eighth nerve in particular. Obviously, with hearing loss, mostly peripheral, could be central though. I mean, you can definitely have that sort of thing in the temporal lobe. And obviously, if somebody's had some hearing loss, we need to get a baseline, do an audiometry, and get that back to us, and be very careful with some of the meds we use. But tinnitus can be very troubling. It's no easy remedy. Sometimes it's so bad people have to do extirpation of the nerve, which is the last option and last choice. Pretty common in our population. Fortunately, only occasionally severe.
We frequently get questions regarding why changes in the moon and changes in the weather can affect our patients. And this is largely due to the impact of pressure changes and atmospheric changes and how it can impact our autonomic system. The autonomic system is what I affectionately refer to as the caveman brain. It's all your primitive functions, your heart rate, your breathing rate, your blood pressure, how your blood vessels dilate and constrict. There's a nausea center up there. Because of the impact on the peripheral nervous system and the blood vessels, it can also be a part of regulating pain responses and sensory responses. So it's not uncommon for our patients to be triggered or have flares in their symptoms as a result of a new moon or a weather front coming in. Dr. Jemsek, could you explain why sometimes Herxheimer reactions or Herxing actually feels like a low blood sugar episode?
Well, there's clearly alterations in hormone balance. So insulin can be very capricious and very labile, so that not a small number of our patients have frequent bouts of hypoglycemia during the day. So obviously they have to eat frequent smaller meals mixed with good carbohydrates, fats, and proteins. One thing to avoid, or at least test, is glutamate, because glutamate can spike insulin and glutamate can spike insulin, and then the glutamate that is in the brain at that point makes you wonky. I said that wrong. So sugar can spike insulin, which will spike glutamate in the brain, and that'll make you wonky. So bone broth is full of glutamate. So if you can handle bone broth, that's not one of your issues as far as insulin control. Just as an aside, the involuntary weight gain that I've lectured on before is related as a metabolic syndrome that goes on with chronic inflammation. This is all about chronic inflammation, folks. And so people have a resistance to weight loss because their fat cells don't want to break down. They're resisting lipolysis because there's inflammation through the macrophages that are in the fat cells, and also microglia that affect the hypothalamus that controls insulin and some of the other hormones, leptin and so forth. Leptin is a hormone that's in regulation with other hormones to break down fat. Well, our cells become leptin resistant, of course they become insulin resistant as well. So there's all kinds of havoc and going on with our regulators of metabolism, particularly as far as glucose metabolism is concerned.
As we've been talking and continue to talk about inflammation in the body, it's important to focus on detoxing or helping the body get rid of the inflammation. If you think about it, the reason why we poop, we pee, we breathe, we sweat is because we're constantly eliminating waste and byproducts of our metabolism. The good news is that you can't really over-detox your body. The bad news is there really isn't one way that's going to take care of all of it. And unfortunately, it's not a one-size-fits-all regime. Some people do better with certain modalities than others. Key things to help with detoxing, one is the diet. That's a way to help avoid toxins going in, whether it be a food sensitivity or sugar, like Dr. Jemsek was discussing. Also, making sure that your bowels are moving regularly, that the normal gut flora are happy, and that your bowels are evacuating on a regular basis. That's a key way to remove waste from your gut. Staying hydrated to help flush the system is really important. Now, be careful not to over-detox your body or over-hydrate your body, because that can cause dangerous issues with your electrolytes. So we do recommend alternating regular free water with electrolyte water. You can add berber and panela. Those are some natural herbs to whatever you're drinking, and they increase the flush factor of whatever you're drinking. Other things like Epsom salt soaks, Epsom salt baths, either full body or foot soaks can be helpful. Just be careful not to do it more than 10 or 15 minutes. Saunas or anything that will help start sweating is a great way to help rid the body of waste. I caution patients who are heat sensitive, as it sometimes can overwhelm your body and actually be more of a stressor. The massage therapy, acupuncture, those are oftentimes beneficial to patients, and they have to do with mobilizing the toxins that get trapped within our muscles and our soft tissue. So helping to get them out of the tissue so your body can expel them is very important. Exercise, as a general rule, you want to listen to your body. Exercise is a great way to rid toxins from your body, as well as boost your natural immune system and endorphins. However, depending on your inflammatory load and in your case, sometimes exercise is actually a stressor. So don't beat yourself up if you can't do more than just stretching and some gentle walking and toning. Dr. Jemsek and I have put together a list of some New Year's resolutions and tailored to the Lyme borreliosis complex patient that we would like to go through with you and hopefully help you get your New Year's resolution straight for 2021. Dr. J?
Thank you, and that was a very good recitation. When Kim says don't beat yourself up, really don't, because if your body's uber toxic, you can't do that salt bath. You get a paradoxical reaction, or then you can only do a foot bath, and you can't do the exercise, and you can't stand a massage because you're releasing too many toxins. So obviously lymphatic massage is what we want. There are a number of goals and motives to do any kind of massage work. Basically, you want to try to move the lymphatics to the extent that you can to get rid of toxins. And of course, the usual elementary waste and all the rest of it is important. Supplements that you think are the best antioxidants. The reason we take supplements is because our endogenous antioxidants, namely glutathione, are exhausted. They're not there anymore because there's a constant stream of reactive oxygen species that consume them. So we have no glutathione. So some people take glutathione outside, which I consider to be okay as a very short-term thing, periodic thing, but certainly not a remedy. But sometimes it helps people get through therapies and so forth. So one of the things we want to talk about is going back to POEMS. The S in POEMS is sleep. we need our sleep. We need our deep sleep. And many of you have smart watches, and you can judge for yourself how reliable they are and what studies are out saying what's what. But we need our deep sleep anywhere from 90 minutes to 2 hours, 2.5 hours, and that occurs in the first half of the evening. Now, several excitatory agents will so when we talk about sleep, we talk about, okay, what's your issue, getting to sleep or staying asleep or both. So some people can't get to sleep because they have busy brain or because they're terrorized or, and so forth. So the first two that we can identify, there are several neuroactive transmitters. Histamine is an activating agent. That's why Benadryl or hydroxyzine, the prescription, can be helpful. So if you have a histamine issue, an easy approach is to take Benadryl or hydroxyzine, and then you get off to sleep. Now, sometimes it's more than one activating agent, so it's not always that simple. The second is glutamate. Again, glutamate's our friend. It keeps us active, alert, and so forth. But when your brain is sensitized, too much glutamate will give you that busy brain. So a good way to block glutamate is taurine, which competes with the receptor sites in the brain and is a very safe amino acid, or theanine, or both, to do that. And then if you are in a norepinephrine excess state, we use medications to block the norepinephrine uptake in the postsynaptic site, and we'll have to use prescriptions for that. Yeah, and we try to use non-prescriptive medications to get people to sleep off-label, which I won't get into today, but if somebody has to take a benzodiazepine and that's all they can do, then that's what we do, because I can't get you better if you don't sleep. For deep sleep, there's a handful of medications that promote deep sleep, including some of the neurotropics, oxcarbazepine or trileptal, gabapentin or Neurontin doesn't work that great, but may work, and then we use some of the older serotonin-promoting antidepressants like trazodone or Seroquel work very nicely in many cases. Mirtazopine's another one. Yeah, and obviously you should follow sleep hygiene, 101, which is, try to get to bed at the same time and keep it dark and cool and all of that. A lot of patients have non-circadian 24 rhythm where, they're just off. And if they're off and they can't go to bed till 4 o'clock and they have the ability, because they have supervision or support, that they can sleep till noon, that's fine. I don't worry about that at all. I don't try to get them back to 11 o'clock at bedtime, because it's not going to work, because that's driven by the hypothalamus and the pituitary, the hypothalamic clock.
Some other resolutions that could be essential to patients with Lyme-Borreliosis complex is your diet. Now, keep in mind, this is something that needs to be tailored to the individual. There's a lot of information out there about low inflammatory diets, but again, it's not one size fits all. Many of our patients have food sensitivities, and those can be very irritating and inflammatory to the entire body. Gluten, sugar, sometimes dairy, depending on how your body reacts. The low FODMAP diet is getting a lot of attention and can be helpful. The ketogenic diet can be helpful, especially for those who have excessive glutamate issues. There's intermittent fasting that can also be helpful for patients with metabolic dysfunction. But we strongly urge you to discuss this with your healthcare provider to find one that is most helpful and safe for you to employ. Staying hydrated, as we discussed earlier, water is super important for your overall functioning as well as detoxing, so make sure you drink your water. Smoking. Most people are familiar with smoking and how it's bad for you. It's bad for your brain, it's bad for your lungs, it's bad for your heart, it's bad for your gut. But most people don't think about it as in terms of being a major source of toxins. And again, this goes from primary smoking as well as secondhand smoke. So if you're spending a lot of time, energy, and money in terms of detoxing, put the cigarettes down, because even if you take one drag, you're introducing a whole slew of toxins and junk into your body. So if that's your motivation for quitting smoking in 2021. Dr. Jemsek, could you talk about the importance of maintaining your spiritual health and well-being in 2021?
Well, I think obviously you have to have some optimism, but sometimes it's not there. I mean, the brain and mind, however you want to separate those out, I guess that's an age-old discussion. sometimes is so damaged that you have no connection with your environment, with your family, with your friends, and so forth. And if it gets to that point, then you're in a danger zone. And someone asked me one time, why do patients with Lyme disease die? And I think they've lost the will to live because they can't connect. But hopefully you have very strong support if you get to that point. And I have seen many people come back from that place. It's not easy, and it's a group effort. But investing in yourself and having a gratitude journal, for example, I always say, patient, things are so bad and bad. I said, well, just humor me, just do 2 columns and write on one column what's good in your life, and then the other what's bad. And they're surprised how many things are good. And I said, well, let's think about those for a while, and let's try to change some of those line items from one column to another, to the other one, and go forward. Having a positive attitude and believing in yourself, and I'll tell you what, most of the patients that come here already have that, because they're not going to put up with the doctor trail that they've been through, and having been dismissed and derided for so long, and even having doubt in their family, which is, we talked about family dynamics last month. And they have an indomitable force somewhere still left in them that says, damn it, something's wrong, and I'm not going to admit that I am crazy, or it's all in my head, or there's nothing wrong with me, like all these other doctors have said, and good for them. And so we have an advantage in the patient population that comes here, because they're already primed to succeed. And when we go through things carefully and explain them and say, oh my God, that makes sense, oh my God. And we've had a lot of tears in our clinic, a lot of tears of joy, and just somebody understands, and somebody's explaining things. Okay, this is why this is, we don't know this. We love to say we don't know, okay? If there are any other doctors out there, that's what the favorite phrase that the patients have. I don't know, but I'll look into it.
And our last New Year's resolution, which I think is extremely important, is with the complexity and the severity of Lyme disease complex. It's very easy to get overwhelmed and just by dealing with this illness. However, it is extremely important that you do not neglect other aspects of your health care. I can't urge you enough to follow up with your primary care doctors, your internists, for your regular health screenings, mammograms, pap smears, bone density tests, prostate exams, colonoscopies. Again, you don't want to become so focused in terms of treating your illness and recovering from Lyme disease complex and find out that you have another comorbid condition. So we can't stress that enough. Well, it looks like we're coming to the close of our Facebook Live. We really appreciate everybody's involvement, and I know that there's some questions that we weren't able to get to and answer today. However, please note I've written them down. We have them cataloged, and we will address them in 2021. Wishing everybody, from myself, a very happy holidays and New Year, and stay safe.
I echo that, and God bless, and we'll see you next year. Thanks for watching.